good morning, everyone, and thank you for asking me to come and talk to you today. I am going to tell you a little bit more about my role as a dietitian and what we do, how we can practically support some of these patients that are going through, for them, probably what is the hardest thing they've ever had to deal with in their lives. There's a little bit of crossover with some of the information that Professor Vasquez has given you, but I'll try and skip over some bits, but just try to give you sort of, say, a bit more of a practical view of what dietitians can do and how they can support patients.
Fiona, may I interrupt for a second?
Of course you can.
Not everybody is a native English speaker.
Sorry,
Can you speak a little bit more slowly, please?
Of course I can, sorry. Always talk too fast. Tell me to slow down whenever I need to. So just a little bit about me. I qualified as a dietitian in the UK in 2006 after studying for a Masters in Dietetics down in Cardiff. Prior to that, I studied in pharmacology actually and worked in marketing and public relations for a few years before transferring over to dietetics. I specialised in esophageal gastric cancer, so only work with people that have got esophageal or stomach cancer since 2008. So I've got about 12 years experience of working purely with this patient group. It's all I do. I'm currently based at the Royal Surrey Foundation NHS Trust, which is in Guildford. It's about an hour outside London in the UK. In the UK, our esophageal gastric cancer is centralised, so not every hospital will see these patients. They'll often stage them, but then we have tertiary referral units, so patients come to these dedicated hospitals and units that only work with esophageal and stomach cancer. So we have very dedicated specialist support for these patients. I work with 4 surgeons and 4 oncologists, and we cover a patient population of about 1.5 million. We see approximately 200 to 250 new patients a year, and about 70 to 80 of them will undergo a curative resection. So we see patients pretty much from the day they're diagnosed, follow them through the staging investigation, so the various different investigations they have to look at the extent of the disease, and then through whatever treatment plan is set out for them, so covering chemotherapy, radiotherapy, and surgery. It's not just me, there's 3 of us in my team that cover these patients, as I say, that purely do esophageal and stomach cancer. We have a blanket referral policy, so we will meet pretty much every patient that's diagnosed in our unit, mainly because if they haven't got a problem with nutrition to start with, we know that at some point during their pathway, they will develop some problems. So we see them pretty much from the day that they're diagnosed, through those staging investigations and throughout their treatments. It makes me really sad to hear some of you just saying that patients feel lost during or after these treatments and they don't know what to do. I think a lot of our patients would be glad to see the back of us. We pretty much pop up every time they come in for an appointment at the hospital. So we give them quite an intensive dietetic support. We're very lucky to be able to do that at our unit. I certainly don't think that's replicated everywhere, and certainly based on what I'm hearing, that's not the case sort of nationally or throughout Europe. So we see them face to face, not so much at the moment. It's a real challenge being able to see our patients in person, but we'll also support them by telephone and email contact as much as they need us. And although there's 3 of us in the team, we try to provide some continuity of care for our patients. So we'll try to see the same patient throughout their treatment. So we can give them a really tailored, supportive nutrition support plan based specifically on them and how their treatments and how their nutritional problems can change throughout their treatments. And we're very lucky that our consultants are very pro-nutrition and very supportive of the work that we do. So we hold multi-professional appointments. Our patients rarely see one professional at a time. They'll see us as a team. So the consultants, the dietitians, our specialist nurses will all see the patients together in that one appointment when they come to the hospital, or over the phone, which is what we do so much more at the moment. So taking a step back, what is a dietitian? There's some variation in the role and the services that are provided across Europe, but generally it's a protected name anywhere across Europe. No one can just call themselves a dietitian. You have to have done a recognised qualification and be registered as a healthcare professional in dietetics to be able to practice in this way. And it's our job really to support new patients' nutritional status, to make sure that any problems they're having with eating and drinking aren't impacting on them as a person, their ability to undergo treatment and their recovery from treatment. So as Professor Vasco was saying, there's a huge amount of research looking at nutrition and its impact on cancer. And most of it demonstrates that good nutrition helps to improve outcomes following a diagnosis. And it's our job to make that happen. With a lot of elements of cancer treatment, patients essentially don't have much of an option. They're given a medication, they have an operation. But with nutrition, it's never quite that simple. Nutrition is kind of eating and drinking is something that we do every day without really thinking about, and trying to get patients to think about the fact that what they're eating is going to impact on their treatment and their recovery can be quite challenging. And we'll look at that in a bit more detail as I go through my presentation. But essentially, it's our job to make sure that nutrition or malnutrition, so a lack of nutrition, isn't going to impact on a patient's quality of life, their treatment options, and their clinical outcomes from that. There's lots of different ways that you can measure malnutrition. Not all of them are all that helpful. There's no kind of blood test that we can do to decide whether a patient's malnourished or not. We can look at their body mass, so their BMI, it's their body mass index, looking at their height in relation to, or their weight in relation to their height. If somebody's got a BMI of less than 18.5, they can be classed as malnourished. But weight loss is something that tends to be used more frequently, and for patients that have lost more than 10% of their body weight would be classified as being malnourished. But it's not as simple as that. There's lots of different factors that can come into play that can make our job easier or harder. But we know from all this research that malnutrition leads to measurable adverse effects on body weight, on body composition, so a patient's muscle mass, and therefore their function, and on their clinical outcomes. So that's kind of why it's important to me. I know from this research that nutrition is important, but why is it important to a patient? As I say, eating and drinking is a fundamental part of our life. It's something that we do every day without really thinking about it. It also has really strong social implications. So much of what we do is, well, not so much at the moment because we're not allowed to do so much socially, but going out for a coffee, meeting friends for lunch, even sitting down for a meal with your family can be a challenge when you can't eat and drink as easily as normal. So if someone can't eat or they're worried about eating, then it can be very socially isolating. So that can have a significant impact, not just on their physical fitness and their ability to cope with treatment, but also on their psychological fitness and how they're going to cope with the treatments that we're going to throw at them. So thinking specifically about esophageal and stomach cancer, we need to think about the anatomy to think about why nutrition becomes a problem for these patients. So the esophagus is literally a tube. It connects the mouth. It runs right through the middle of the body, which is why it makes it quite challenging when we have to remove it. You've got your lungs on either side, but essentially it's just a tube that takes the food from the mouth down to the stomach. The stomach is then a carrier bag sitting at the bottom of the esophagus that can grow and expand to fit food into it, and churns it all up into a liquidy substance and sends it off into the small bowel where it's actually digested. So if you've got a tumour sitting in any part of your esophagus, it's going to narrow off that tube. It physically makes it harder to get the food down through to the stomach. So patients can present with something called obstructive dysphagia, where they can feel food, they can swallow it fine, but they can feel it sticking as it's going down through into the stomach. Mostly patients report bread and solid meat as the first things that they notice tend to cause a problem. But a lot of patients we find are down to just managing a very soft diet or even liquids only by the time we meet them. That physical obstruction is stopping the food from getting into the stomach. Patients with gastric cancer have a tumour that's affecting how that stomach can respond to the food arriving in it. It can't grow and expand in the way that it should do. So patients can get something called early satiety, or a feeling of fullness, because the stomach can't grow and expand as they fit food into it, so it stays quite small. So they feel full after a small amount of food, so they eat less. They can get nausea or vomiting because the stomach's not emptying properly, and they can get abdominal pain. So all of these physical factors from the tumour can affect how much a patient is eating or the way that they're eating. But on top of that, they can get other factors that affect their appetite. As I said, they can be quite socially isolated because you don't want to sit down and have a meal with your family if every 5 minutes something's getting stuck and you're having to bring it back up again. So they don't eat around people, therefore they don't eat as much. There can be a lot of fear and anxiety around eating. They're worried about what's causing the problem, so that can reduce what they're eating. They can get a lot of loss of appetite. Appetite is a very complex thing that's affected by lots of different factors. But if you feel it's difficult to eat, you're worried about eating, you don't want to eat with other people, you tend to eat less, they get a reduced dietary intake, and they experience malnutrition as a result of that. So we know the symptoms of esophageal and gastric cancer can cause high risk of malnutrition. There's a lot of data looking at it. Some of it's quite old now. Actually, it'd be quite good to get some more recent research looking at the state of malnutrition across Europe. But it suggests that about 80% of patients have over 15% involuntary weight loss at the time of diagnosis. So that's quite significant right from the beginning. The first time we meet people being diagnosed with cancer or this type of cancer, they're already struggling with malnutrition, which means, as Professor Ravasco was saying, that they lose their muscle mass, they reduce their physical fitness, their ability to do things, they're more tired, and all of that's impacting on their fitness for treatment, their quality of life, their immune function, and their ability to cope with the treatments that we're going to throw at them, and therefore their outcomes and recovery. So we know these patients are struggling from diagnosis. We then throw them through a complex multimodal treatment pathway. So for most of these patients, their treatments aren't simple. It's not one answer. It's not chemotherapy, radiotherapy. It's generally a combination of chemotherapy or even chemotherapy and radiotherapy, then surgery, and then more treatment afterwards. So these are aggressive cancers that need to be treated with a huge amount of treatment that actually then continues to have an impact on their nutritional status. But their symptoms can change throughout their treatment. Chemotherapy and radiotherapy can be positive in terms of what the impact it has on a patient's nutritional status. Some of those initial symptoms that they can present with, so the difficulty swallowing, the obstruction feeling that they get, or the early satiety, as a tumour responds to chemotherapy, that can improve. And actually for some patients that we meet that will be down to just managing liquids on diagnosis, after a couple of cycles of chemotherapy, their swallowing can improve and therefore they can eat and drink better. So they're likely to improve their nutritional status. But the treatments that we give them can also be quite toxic and can give them nausea, vomiting, taste changes, things just don't taste the way that they should do. That again can affect your appetite. They can get change in bowel function, that again can limit how you feel about eating and your enjoyment of food. And patients undergoing radiotherapy can get a dynaphagia or pain on swallowing. So there's lots of things that can improve on treatment and lots of things that can get worse. So symptoms can change for these patients a lot as they go through their treatments. And we know from research that if patients are going into these treatments with malnutrition, they're more likely to experience worse symptoms. So a malnourished patient gets more toxic symptoms from their chemotherapy. So they get worse nausea and vomiting, worse taste changes, they get more tired, which further reduces their dietary intake. So you get a bit of a vicious circle. Patient becomes more malnourished, which results in delays to treatment, reduction of their treatment dose, which reduces their quality of life and is likely to lead to poorer outcomes. So anything that we can do for these patients to help to support their nutrition and make things better is going to improve their ability to cope with their treatment and to improve their outcomes. For a lot of our patients, we're then asking them to undergo a huge operation. Esophagectomy or gastrectomies are hugely complex surgical procedures, and they're associated with high surgical related complications. Again, huge amount of research looking at the impact of nutrition on these procedures. And there's a lot of evidence to show that patients that are malnourished when they go into theatre have a higher risk of morbidity, so surgical complications, higher risk of mortality, so dying as a result of their operation. They tend to stay in hospital for longer. They're more likely to be readmitted to hospital. They have increased costs of healthcare, so they need more support, more intervention, and all of that is impacting on their quality of life and their recovery. So we know by improving a patient's nutritional status prior to and during cancer treatment, we can improve their tolerance, their adherence to neoadjuvant therapies, so their chemotherapy and radiotherapy. We can reduce their post-operative complications, and we can improve their overall survival and quality of life. it's pretty important that we get these patients as well nourished as we can do at every stage of their treatment. But it's really challenging. They can present with complex nutritional challenges. So we've just spoken about the impact of the physical obstruction caused by the disease, the toxicities that they can get from treatment. But patients are rarely that simple. They often have other nutritional issues like diabetes that can impact on what they're able to eat and drink. They have lots of preconceived ideas about eating and drinking and what their preferences might be. So it's not as simple as just saying, this is going to solve the problem. There's often lots of different things that we need to take into account with these patients. We've also got fairly rigid time constraints. Once a patient is diagnosed with their disease, they've been through their staging investigations, we need to get on and treat them. We can't just sit back and have some time to be able to support these patients. We need to get on and treat them as quickly as possible. So we don't have a lot of time to reverse the problems that they might be presenting with. But they're generally a fairly highly motivated patient population. They're quite keen to do whatever they can to improve their outcomes. And nutrition or eating and drinking is something that they can have some control over. They often feel sort of out of control once they've had a diagnosis and being told what the treatment plan is. Actually, nutrition and what they're eating can be something that they control, they can help to make better. So you get what's called a teachable moment when patients are more likely to take in what you're telling them and put it into practice. And it's partly our job to help to motivate those patients to make those changes and put it into a really practical way of how they can improve things and make things better. There's still lots of research, lots of debate about the best way to manage a patient's nutrition. There's certainly no one size fits all as to this is what's going to work for everyone. And certainly from our practice and our experience, we very much feel that patients need a very individualized, specific to them way of managing these problems. And it needs to be flexible. It needs to be able to change based on who they are, what their treatment is, what their treatment outcomes are, how things are changing for them as they go through the various different stages of their treatment. So what can we do to help? We're going to go through this in a little bit more detail, but our job is to identify those patients that are having problems and to support the clinicians into what we need to do to support these patients as they're starting and going through their treatments. And there's a number of different strategies that I'll go into in a little bit more detail. So in terms of identifying patients, there's a number of different ways of screening a patient for malnutrition. This is from guidelines developed by Professor Lowe last year, which looks more specifically at nutritional risk in esophagogastric cancer, so taking into account dysphagia as being one of the problems that patients present with. So patients with severe dysphagia or difficulty swallowing that are down to only managing puree diets, so very smooth textures, or liquids only, that have lost more than 10% of their body weight or have that BMI of less than 18, they consider to be at high risk. So that's a fairly simple way of looking at whether patients are malnourished or not. But in our unit, we're very much, as I say, want to be very specific, and all of our patients will undergo a much more extensive diagnostic nutritional screening plan. So we spend a lot of time talking to our patients about what their problems are specific to them, why they're struggling, and what we can do to try and support them a little bit more. We, as I say, want to make sure that these plans are very personalised, very specific, frequently reviewed and adapted to make sure that we can offer them the best support that we can. Dietetic counselling is obviously one of the first things that we'll do to try and support a patient, and through it we can improve their food intake and address the number of symptoms that they may be experiencing. We'll also look at other factors that might be affecting their nutrition, such as diabetes, and assess their readiness for change. So some of these patients are going to need to accept that they need to change their dietary habits. And for a lot of our patients, they're in their 60s, 70s, 80s, got dietary habits that they've been in place for many, many years, and trying to change people's ideas of what they're eating, how they're eating, the timing of when they're eating can be really challenging. But we want to motivate them to make those changes so that they can improve their nutritional status and therefore their outcome. Some of the strategies we might use is looking at texture modification. So even though patients are struggling with getting food down, they might still be persisting, still trying to eat some bread or some meat when they know they can't do it. So trying to help them to make the right choices of softer foods, things that they can chew more to get down, is going to be easier to manage. We look at adapting their food choices, going for higher calorie food options. And again, this can be a real challenge. We meet a lot of particularly ladies in their 50s or 60s that have followed very healthy eating patterns for most of their lives, and suddenly having to accept that higher calorie foods, things like cakes, biscuits, full fat yogurts, are what they need to be doing, can be a really difficult thing to accept, and a difficult thing to change to. So we try to support them and help them to understand why those differences are necessary. Also, although we see a lot of patients that have lost a lot of weight, we also see a lot of patients that have started off with a very high BMI, so patients that are overweight. And some of the advice that we might be giving at this stage might be looking at appropriate weight management for this advice, which for this patient, which can be a difficult thing in cancer dietetics to help to manage. But for our patients that are going on to have complex surgery, if they're very high BMI, that can make things more complicated as well. So there's lots of different problems that we can come across with these patients, as I say, that need a very individual way of supporting them to make sure that they're getting the best outcome. So some of the advice that we can give can help to manage some of the side effects of the oncological treatments, as you mentioned earlier, about taste changes can be a really difficult thing. Patients just lose their sense of taste, or everything can taste a bit metallic or just not right, and therefore they don't want to eat it. So they need, excuse me, a lot of help to understand why that's a problem. And just because things taste different, or their appetite is not there, they're not really interested in eating, doesn't mean that nutrition isn't important. Just because their body isn't telling them that they need to eat something doesn't mean that actually they need to. So we give them a lot of advice and support on very practical strategies of how to manage that, and how to cope with some of the problems that might come across as a result of their treatments. One of the tools that we might use in our box is oral nutritional supplements. So there's a lot of different products produced by different companies that are designed to improve a patient's nutritional status. Some of them help to fortify the diet, so they're powders or liquids you can add into food to increase the amount of calories or protein in there. Or there's some like the 40 Sips, which are a high calorie drink that contain a good range of carbohydrate, protein, fat, and vitamins and minerals, again, to supplement what patients might not be able to get from eating and drinking. A lot of doctors think they're a very simple, easy to use thing. They just prescribe 2-3 a day and expect patients to drink them, but actually it's rarely as easy as that. And there's a lot of sort of patient preference around these type of products. So we try to use lots of different things and different ways for patients to take them to improve their compliance, but they're one of the things that we can use to help. So we can talk to them about their food and what they're eating. We can give them products to help to improve their intake. And one of the more invasive ways that we can help to support these patients, but it's actually quite important in this patient group, is using feeding tubes. For some patients, they can get a complete physical obstruction, so they're not able to manage to eat and drink in a normal way. So we might need to use a feeding tube to support their needs. The timing of tube placement can vary significantly based on treatment, but also where you're being treated and how it's being managed. And there's still a lot of discussion about the optimal timing of when this should be done. And there's different types of feeding tubes that we can use, either a nasoventral tube, so a tube that goes in through someone's nose and down into their intestine, or direct tube, something called a jejunostomy, which goes in sort of at skin level. So various different hospitals will use different types of tubes at different stages, but it's just another tool, another way of getting nutrition into a patient to support their nutritional status on treatment. So nutritional surgery is also a really important factor to be thinking about. Surgery itself causes a huge physiological stress on a patient and causes the body to burn through calories really, really quickly. So patients that are going, as I mentioned earlier, going into surgery that are malnourished have a much more higher risk of complications as a result of that surgery. After the surgery, the oral intake can be significantly limited for the first week or two. As the healing process is happening, you get what's called an anastomosis, where they join the two bits of tissue together, limits what a patient is able to eat and drink. And we frequently use feeding tubes to support patients at this stage to support their recovery. But we're aiming to limit the impact of surgery on their nutritional status and limit the impact of undernutrition on their recovery. All forms of esophagogastric surgery can change the structure and the function of the stomach. So it's not just the immediate recovery phase that can be challenging when patients physically can't eat and drink. It's the longer term impacts of this operation that we consider to be quite challenging. Patients lose that gastric volume. So as I mentioned earlier, the stomach is like a bag that can grow and expand to fit food into it. Once you've had an operation that reduces the size of that or changes the function of it, with an esophagectomy, the stomach is brought up into the chest. So you just haven't got that volume to manage food or ability to churn it up. So it completely changes. What have I done?
What was done now?
Got it. So it completely changes the function of the stomach and the small bowel. It's like the plumbing has been completely changed for these patients. So their ability to eat and drink normally it's very, very different. You get an increased transit time, so the food passes through the system much quicker. Therefore, your ability to digest it and absorb it is not as good. Your appetite is just not there. Patients after this kind of surgery need to eat 6-7 times a day. And if you don't feel hungry, that can be a really difficult thing to manage. And also their digestive process changes. The pancreas is an organ that produces enzymes that help to digest food, and it just doesn't work as efficiently as it would have done normally. So there's a huge impact of this kind of surgical operation on not just a patient's ability to eat and drink, but the way that food is digested afterwards. So they need a huge amount of support to be able to recover adequately from this kind of surgery and regain that quality of life that they might have experienced beforehand. Some of the things that we might help to manage that is we talk to patients a lot about changing their habits. They need to eat small, frequent meals. They need to chew their food really well to allow it to get through the system. They can't drink a large amount at the same time as eating. They need to make sure the food that they're eating is very high in calories, high in protein. So again, can be a change for patients in terms of food choices they might have made beforehand. They can get problems with something called dumping syndrome, when the food passes through the system too quickly, make you feel very lightheaded, a bit dizzy, causes some tummy pain after eating. As I mentioned, they can get loss of appetite. They just don't want to eat because it causes pain. It can change their bowel habits. So your patients can experience a lot of diarrhea or constipation after this kind of surgery. You can get a lot of malabsorption. As I said, the pancreas doesn't work as efficiently as previously. So there's a huge number of problems these patients can experience as a consequence of this kind of surgery, and they need long-term follow-up in multi-professional clinics. A lot of our consultants that we come across, surgeons that will think, oh, we've done the operation, they've survived, they've got home, well, job done, that's brilliant, they're managing fine. But actually, if you dig into things a bit better, they're not eating well, they're losing a lot of weight, they're getting a lot of problems with pain or difficulty swallowing. So it's not just surviving this operation that's important, it's about managing the consequences of it, ensuring that patients can regain a good quality of life after having had this kind of surgery, hopefully to cure their cancer. And just briefly mentioning patients, not everyone is in a position to have this kind of curative surgery. And some patients with advanced disease or recurrent disease might have ongoing nutritional problems relating to that. Obviously, our focus is slightly different in terms of optimizing their nutrition. It's still supporting their quality of life, but you're looking at symptom management and enjoyment of food in a slightly different way. In esophageal cancer, patients are going to present with that problem of obstruction again, as the tumour can develop within the esophagus and make it very difficult to swallow. So for some patients, that involves having a stent placed, which is like a metal mesh tube that opens up the esophagus to allow people to eat and drink a little bit better. But it's not like a normal esophagus, so they're still going to need some advice and support on how to manage their nutrition once a stent has been placed.
Fiona, if I may suggest that you skip over those slides and go to the summary, because we are a little bit
running out of time.
Yes,
no,
thank you.
That's fine. So I just mentioned briefly that these slides, I'm sure Zorana can make them available later, but we were just looking at the difference in the amount of dietetic support across Europe and across the UK, which varies hugely in terms of where dietitians are available to provide this kind of support. So just to summarise, good nutrition is really important for cancer patients at all stages of their treatment pathway, and particularly for patients with esophagogastric cancer. They're at high risk of malnutrition, and they frequently experience nutritional challenges due to the disease, but also from the impact of the treatment that we're expecting them to undergo. Nutritional optimization can help to reduce some of those complications associated with their oncological and their surgical treatments, and ultimately improve their long-term outcomes. Specialist dietitians should very much be an integral part of patient care. Not just any dietitian, but patients that work specifically with a patient group that understand the problems they can experience and the proper times to try to optimize their care. And these patients need a really personalized nutrition plan specific to them. There's not one size fits all approach. At the moment, as I say, there's a huge variety nationally in the UK and across Europe to the access to specialist dietetic support. So it's something that we're desperately keen to try and improve. A dietitian can make a huge difference to these patients, to their quality of life, to their day-to-day management, and to their outcome from their cancer. So we'd really like to see more patients getting access to this kind of support.